ladies and gentlemen. Good morning. The first presentation is, Mr. President told, lead thrombus, a patient with pacemaker after 6 years. As we know, first cardiac pacemaker was implanted in Sweden, and in the first time they put the pacemaker with thoracotomy, and we have some complication in pacemaker implantation. These some of these complications are dependent on the doctor qualification. Some of them is technical problem. These complications: pneumothorax, bleeding, pericardial tamponade, hematome, pulmonary emboli, contraction of diaphragma, pacemaker syndrome, pacemaker-mediated tachycardia, inefficient capture, problems due to output, problems due to undersensing, electromagnetic interference, electrocardiographic interference, lead infections, these complications, and also lead dislocations, skin erosion, and accumulation of sterile fluid in pacemaker pocket. In our case, the important point of this case is to emphasize that the pacemaker lead thrombus occurred in a 3 weeks period, although patient has pacemaker in last 7 years. 74 years old Caucasian female patient brought into emergency department for an acute onset and deteriorating dyspnea, and a DDR pacemaker was implanted 7 years ago because of complete AV block. Previous routine follow-up exams and pacemaker technical values were within normal limits in all 7 years. But atrial fibrillation was detected in last follow-up, which was done 1 month ago before detecting thrombus in pacemaker lead. In transthoracic echocardiography, we saw a thrombus attached to the pacemaker. Its dimension is 1.5 and 3.0 centimeter in the right atrium. I will show it. As you can see in here, I'm sorry. In here you can see the thrombus, and also this is thrombus. Patient was admitted to cardiovascular surgery intensive care unit with a plan for surgery because of large thrombus. Electrode-associated right atrial thrombus appears to be relatively common in acute period after pacemaker implantation, and it's usually asymptomatic. And patients' previous follow-ups were within normal limits in 7 years. Probably an electrode-associated right atrial thrombus in this case has been happened. After the onset of atrial fibrillation, it was done. We thought that it was done in last 3 weeks. It happened, and at that time, the patient she was not taking any anticoagulant agent. In this case, the important point for this case now, there was no thrombus formation in last 7 years after pacemaker implantation. It's important that anticoagulation treatment should be started as soon as possible when atrial fibrillation is detected in patient with pacemaker, also in every patient. Thank you very much.
Okay, is there any question or discussion or comment?
Shock incidence happens in especially electrical workers. Electric can cause multisystemic injuries and mortality. In the late period in the heart, electric also can cause fibrosis in the myocardium. These cases were seen rarely in low voltage to 220 voltage electric shocks, and low voltage mortality is risk mortality. In low voltage electric shocks, arrhythmia is the most complication of these shocks. Electric shocks induced myocardial infarction is a very rare condition. Coronary vasospasm and coronary thrombus happen due to low voltage electric shocks, and it results in myocardial ischemia. Mostly coronary angiogram of those patients are usually normal. and the right coronary artery is the most affected artery. Why the right coronary is the most affected artery? The location of right coronary artery is responsible for this condition. 49-year-old female patient was admitted with acute coronary syndrome after a low electric shock. In electrocardiogram, ST elevation were seen in inferior leads. The coronary angiogram revealed coronary artery spasm and right coronary artery dissection. The complete revascularization was achieved by implantation of a bare metal stent in dissection, part of right coronary artery. In this video, I think I will show it. You can see right coronary artery in here. Here some vasospasm you can see, and a small dissection in the first part of the right coronary artery in here, as you can see. Dissection in here and vasospasm in here. We put a bare metal stent in proximal part of the right coronary artery in here. After the implantation of stent, we can see the right coronary artery. Thank you very much.
Okay, paper is open to comment, discussion. Any?
As we know, rheumatoid arthritis is a chronic multisystemic autoimmune disorder, and it's primarily affect joints and the connective tissue. In all population, it's seen about less than 1%. The multisystemic manifestation involves skin, kidneys, lungs, heart, and vessels. But the manifestation of vital organ can lead to morbidity and mortality, especially heart and the lungs. The cardiovascular death is major cause of the mortality in rheumatoid arthritis. And the patients are prone to atherosclerosis, and risk of myocardial infarction and stroke is 50% increased. Interstitial lung disease, another manifestation of the rheumatoid arthritis. 40% of patients with rheumatoid arthritis has interstitial lung disease, and only 25 of these patients can be diagnosed clinically. 75% of patients with interstitial lung disease are clinically silent, and it can be diagnosed with high-resolution CT scan. Interstitial lung disease is the cause of the mortality in 7% of patients with rheumatoid arthritis. The mortality risk increases 3 times when a patient with rheumatoid arthritis is diagnosed as interstitial lung disease. And when the interstitial lung disease is diagnosed, the survival is only about 2.6 years. The poor prognosis and difficulty of the diagnosis emphasize the importance of early diagnosis, which may guide the investigation for a therapy and better survival duration in the future. The other issue, the pulmonary arterial stiffness, is an important indicator for right ventricular function. Increased pulmonary artery stiffness ends up with pulmonary artery endothelial dysfunction. Pulmonary arterial stiffness is independently associated with functional capacity, and it's a stronger predictor of mortality than pulmonary artery pressures. In this study, we evaluated pulmonary arterial stiffness in patients with rheumatoid arthritis and compared the results with healthy population for the assessment of lung involvement and the early interstitial lung disease. Pulmonary arterial distensibility has been investigated using MRI and echocardiography. It has been found well correlated with the severity of the pulmonary hypertension. The aim of this study was to investigate whether echocardiographic measurement of right pulmonary artery distensibility may be of value in assessing the presence of pulmonary disease before it is symptomatic or it can be diagnosed by conventional methods. 43 patients with rheumatoid arthritis and age-sex measured 18 health subjects recruited for the study. The rheumatoid arthritis group was clear of lung involvement. I want to say especially the rheumatoid arthritis group was clear of lung involvement in chest X-ray, not tomography or MRI. Mean pulmonary arterial blood pressure is normal in both groups. It was detected by echocardiography. In addition to conventional echocardiographic examination, all subjects were evaluated for right pulmonary artery distensibility index, which is calculated as the difference in diameter of the right pulmonary artery in systole and diastole. All echocardiographic measurements were done by two cardiologists, and the inter- and intra-observer variabilities were less than 5% for all the measurements. Mean right pulmonary artery distensibility was 0.17 in patient group and 0.21 in control group. Right pulmonary artery distensibility was higher in patient group, but there was not a statistically significant difference for right pulmonary artery distensibility between patient and the control group. According to our results, right pulmonary artery distensibility index is worsened in patients with rheumatoid arthritis, but it is not significant. Maybe our the number of our cases is low. Our study is going on now. Maybe in the future it will be better than now. Thank you very much.
Thank you. His paper is open to discussion.
Atherosclerosis is a chronic inflammatory and focal disease of the middle and large arteries, and it also also coronary arteries and popliteal arteries and internal mammary arteries are middle-sized arteries, and they are prone to early atherosclerosis. Aortic pulse wave velocity is a classic index of aortic stiffness, is easily measured using non-invasive ultrasound methods of high reproducibility. Among the non-invasive and simple methods of evaluating arteries pulse wave velocity, measurement is widely used as an index of large artery elasticity and stiffness, especially large artery elasticity. But in this study, we use it in the middle artery. I mean, the show of the evaluation of the middle-sized arteries level condition. This method is simple, accurate, and reproducible, and thus can easily be applied for the evaluation of cardiovascular risk. Conventional risk factor atherosclerosis are a sign of extension of atherosclerosis, and their existence correlated well with pulse wave velocity. Internal mammalian artery is the most widely preferred artery by the cardiovascular surgeon in the anastomose in coronary artery bypass grafting operation. Because internal mammalian artery is also an artery and that's prone to atherosclerosis, the size and the blood flow through EMA has always been an interest of surgeons preoperatively. We investigate the relationship between pulse wave velocity and EMA size and blood flow in patients who are candidates for CABG. We recruited 21 patients planned for CABG operation. Aortic pulse wave velocity values were evaluated by echocardiographic methods. EMA size and flow parameters are evaluated intraoperatively by cardiovascular surgeons. We used Doppler ultrasound synchronized with ECG and 2-second minimum sliding window. The examination began with the patient in a supine position. After location the carotid artery with B mode at supraclavicular level. We then identified the wave Doppler flow simultaneously with ECG. The process was repeated on the common femoral artery in the groin. We performed 3 recordings of the carotid artery and 3 recordings of the femoral artery. Each recording involved 2 or 3 cardiac cycles. To find the transit time, we measured the time from the R wave of QRS complex to the foot of the waveform using digital calipers. Like this is, as you can see in here. From here to from here. According to early result of this prospective study, mean aortic pulse velocity is 9.3 millimeters seconds in a second per second. Mean internal mammalian artery diameter was 1.5 centimeter, and mean internal mammalian artery flow was 29.2 cc minutes. We found a statistically significant correlation between EMA flow and EMA diameter, but there was no significant correlation between the EMA flow or diameter and the pulse wave velocity. According to our study, our aortic pulse wave velocity cannot predict EMA flow or EMA diameter. Thank you very much.
Thank you.